Good evening, everyone. I welcome you all to this webinar. I mean, uh, since we are celebrating the newborn week from 15th to 21st of this month, we thought we'll have some guest lecture for our residents also. And it was actually on a very short notice that I invited sir, and it is, wonderful that he accepted the invitation on the last minute, and he was ready to, be a part of this webinar. So I thank you for that. And sir has done his MBBS from MGM Medical College Indore, and then he has done his MD Pediatrics from Government Medical College Bhavnagar, and recently he has completed his DM in Neonatology from Christian Medical College Vellore, and he has many feathers to his hat, and waiting to hear from you, sir. The stage is yours now.
Okay. So thank you so much for the wonderful introduction. So what is so we have our audiences, postgraduates and practicing pediatricians, and
Yes,
so
sir.
this is our audience. This is our audience.
Yes, yes.
Okay. So this is from the audience is from Kutch itself, or it's like from around Gujarat or something.
So many of them are from Kutch only, sir. Many of them are from
Okay.
Kutch
Okay.
only. But then a few of
Okay.
them, I
Nice.
think, they have joined from other places also.
Okay, okay, okay. Nice, nice, nice. So, okay. So good evening, one and all. So today, what we'll be doing is we are going to discuss one of the very, common issues which we face in neonatology, but at the same time, it is one of the most commonly missed issue of units. Okay, so hypoglycemia is one of the most common, but at the same time, it is one of the most common missed phenomenon what we are actually seeing in neonates. So, what we are going to see in the coming few slides in the next 1 hour, my idea is to uh, make an impression on the audience, to make the audience know that what is neonatal hypoglycemia, why you should know about neonatal hypoglycemia, why it is important to know about why sugars are low, a low sugar baby might have what problems in future, how to diagnose it, how to manage it, we'll be seeing in the next few slides. Glucose is actually the first fuel for neonate. The first fuel for a neonate is, for your car your fuel is petrol or diesel. For a neonate, the first fuel for neonate is glucose. So please, my request is, please don't let that fuel run low. Okay. So the outline of my talk will be, we'll be seeing what happens to glucose once the baby is born. Okay. What How the glucose levels are being maintained in the body. We'll be also seeing what is neonatal hypoglycemia. That's a lot of variation, lot of controversy also. Next, what we'll be doing is we'll be discussing which babies to screen, when to screen. This is very important so that the right population is being screened, and till what time to screen. We'll be discussing that. Now, some questions about why this hypoglycemia occurs, why not all neonates develop hypoglycemia, why only a specific category develops hypoglycemia. We'll be seeing that also. So once we have diagnosed hypoglycemia, how to manage that hypoglycemia, what all parameters to be checked, what all medicines are there, or what all therapies are there, we'll be discussing that. Then we'll be briefly talking about on a very common, not a very common, but a kind of a rare phenomenon, recurrent or persistent hypoglycemia. But at the same time, people don't know, the pediatricians don't actually know how to manage this kind of phenomenon. So we'll be touching on the recurrent and the persistent hypoglycemia, how to manage that phenomenon, and how to go through it, what all investigations are required. We'll be touching on that. And lastly, we'll be also discussing what are the outcomes of a baby having hypoglycemia, and hence why should we be more worried about a baby developing hypoglycemia. So we'll be starting our presentation. So basically, once the baby is in utero, okay, so the glucose is being supplied through the maternal plasma, okay, through its diffusion through placenta. So once your delivery happens, once the delivery happens, the placental link is interrupted. So what happens at that time? Now the baby has to, maintain sugars on his or her own. Okay, so normoglycemia is achieved by some metabolic and hormonal responses. What are these responses? Okay, there might be glycogenolysis, glycogen breakdown might happen, gluconeogenesis might happen, lipolysis might happen, ketogenesis can happen. How these all processes start or happen, it depends on a variety of hormones. Okay, so if we see, once the baby is born, the initially what happens is now the baby wants to maintain sugars. Okay, so sugars need to be maintained immediately. A lot of babies don't get any nutrition, but the maternal supply is being now cut. So now baby needs to maintain sugars on its own. How he can do that? Initially, what happens is insulin levels they start falling. Okay, now once insulin levels start falling, so the glucose in the body is there for the baby to utilize. Okay, so initially once the baby sugar is around 85, so at that time the insulin levels will start falling so that baby develops more stores of glucose. At that time, baby won't develop any symptoms. Later on, what happens is once the insulin levels start falling, still sugars are not under control. The next process, what is happens is glucagon and catecholamines at that time increase. Okay, so glucagon, epinephrine, growth hormones, these all catecholamines start increasing at that time, so that baby's sugars start increasing. So after once this process happens, the next few hours of life, glycogenolysis happens. If sugars are not there in the numbers are not adequate for the baby will start utilizing its glycogen resources. Once glycogenolysis is set, the next is gluconeogenesis. So once baby sets in gluconeogenesis and lipolysis, that is not a very good situation. Baby should be given more of feeds so that this gluconeogenesis, lipolysis and ketogenesis they don't happen. That is our target. Okay, so during the same time, so at 85 around levels, your insulin levels start falling. Once the baby's sugar start dropping around 60 to 75, the glucagon starts increasing, catecholamines start increasing. Once sugars further persist to fall, at that time growth hormone starts increasing, cortisol levels start increasing. So this is how actually a sugar is being maintained in a baby once the placental link is interrupted. So now the question is how to know that a baby is hypoglycemic. Okay, so a lot of you will see ki, sir, baby might be dull, baby might be not feeding well. Yes, definitely. So basically, those are the common symptoms, but we can categorize into two types of symptoms. One is the autonomic symptoms, and one is the neuroglycopenic symptoms. So autonomic symptoms, baby will be sweating more. There will be tachycardia. Baby will start having tachypnea. Okay, some tremors might start happening. Mothers will complain ki sir, baby is having jitters. Once, oh, you will be counseling, that's normal jitters. You will be counseling that, okay, tremors are common, jitters are common. Okay, but the tremors and hypoglycemic jitters, that will be completely different as compared to the normal tremors or normal jitters. Okay, so if you compare the baby's sugar. Uh, are my slides visible?
Yes, sir.
Okay, okay, okay. So that is your autonomic symptom. So neuroglycopenic symptoms will what will happen at that time is mm, sorry for the disturbance. So neuroglycopenic during that time, what will happen is the sugars in at the level of brain at that time the sugars in the brain, which is the main fuel for brain, is glucose. So at that time the baby will start developing symptoms. What will be those symptoms? Baby will start having lethargy. Baby will start having seizures. The suck won't be very good. There will be an abnormal cry. The cry will be very different from the normal cry what a normal neonate has. That will be a weak high pitched cry. So once you are seeing a baby having a high pitched cry, baby's having tremors, jitters, baby's having a very poor suck, please at that time check the baby's sugar. That will definitely help you in further management. Now the next question arises, okay, sir, we know the symptoms, we know the signs, okay, we know how the sugars is being monitored in the baby, but at now I have seen a baby, okay, baby was having some tremors, baby was dull. So I checked the sugar. Now the sugar is 48. Is that baby is just 2 hours old? Is that sugar low, or is that sugar I can still manage like a normal neonate? So here confusion starts. So confusion starts is the definition of hypoglycemia. Okay, so definition of hypoglycemia, different societies will be giving different sets of values. Okay, so for example, if we see the American Academy of Pediatrics, in the initial 4 hours, what it says is less than 40. Less than 40 is the sugar where we can consider it as a hypoglycemia. After 4 hours, the sugar is less than 45. Okay, first 4 hours less than 40, after 4 hours less than 45. Similarly, the British Society says anytime the baby's sugar is less than 36, consider hypoglycemia. Canadian Society says less than 47, while Pediatric Endocrine Society says less than 50. So the WHO parameters is less than 47 milligram per deciliter anytime during the baby's life is considered as hypoglycemia. So if you want to stick on to one definition of hypoglycemia is you just take a value of less than 47, consider that as hypoglycemia. So we during at our residency in CMC Vellore, what we used to take as hypoglycemia was initial first 48 hours less than 45, consider hypoglycemia. After 48 hours, if the baby is fine, consider any sugar less than 60 as hypoglycemia. Okay. So, for example, if a baby is around 72 hours old, baby's sugar is 50. Yes, that sugar is low for that baby. Okay. After 48 hours, more than 60 should be maintained. And before 48 hours, baby should be maintaining more than 45. So, why these kind of parameters change? Why these kind of values are, different for different societies? Okay, so the question arises why WHO says 47, why AAP says 40. Okay, so what they have done is they have done a lot of studies on this. A lot of studies have been done in Okay. And then they see at that point, they see ki what is happening, at what sugars babies do develop symptoms, at what sugars baby do have neurological outcomes which you can relate to hypoglycemia. So AP would have done a study where they would have seen that less than 14 initial few hours had neurological outcomes pertaining to hypoglycemia at around 2 years, 3 years. So then they would have fixed that at 40. Similarly, Canadian Society would have done studies which showed that okay, babies less than 47 usually have a new long-term neurological outcomes of hypoglycemia. So different societies will give different values. What you need to do is you need to pick a value of your own. Okay, if you want to be safe, if you want to be medico-legally correct, take a sugar less than 47 anytime during baby's life as a hypoglycemic value, and then you need to manage accordingly. So now you have know that the sugar is what normal values of sugars are, what hypoglycemia is there, what when is hypoglycemia considered as significant. Now the question arises: you ask, you are there in your postnatal wards, and you see, you hear a complaint. Mother is telling the baby is not sucking properly. Initially, baby is very sleepy. He's very lethargic. He doesn't wake up very often. You suspect that it could be a hypoglycemic event. Okay, so you ask the staff to do a sugar testing. At that time, the value shows 60. Okay, your glucometer shows a value of 60. So, what is the probable lab glucose value at that time? Any answers? Okay. So the answer is, so whenever we are doing a sugar by your glucometer and the sugar which we do in laboratory, the lab glucose value, those are particularly different from each other. So what you are checking is your blood glucose, and what you are checking in your laboratory is your plasma glucose. So plasma glucose will be at least 10 to 12% higher than your sugar which you are checking in your random blood sugar. Okay, so that will always be higher, 10 to 12%. For example, if you get a 60 in your RBS in your ward, and then if you send a lab value at the same time, so you will get a 10% higher. It might be 66, it might be 70. This is why this is important. Why you should know this is, this is not very important if the sugars are normal. But if the sugars are running low, for example, if you baby is admitted in nursery, you get a sugar of 45, or you get a sugar of, for example, 30. Okay, at that time you need to concomitantly send a lab glucose value. Lab glucose value, you need to send it immediately. Okay, that sample has to reach the lab immediately. So at that time you will know that the actual glucose value is around 36, around 40. So that is the time where you should act immediately. Okay, so RBS in your glucometer and your sugar in your laboratory, those are not similar. The plasma glucose will always be 10 to 12% higher than your random blood sugar. Okay, so the question arises, as I told you that your glucose level, if you're taking in your in the vial, you need to be, it needs to be heparinized vial. Okay, fluorinated heparinized vial. Okay, and you should send the sample as soon as possible to the laboratory. Why? Because the glucose level can fall up to 6 milligram per deciliter per hour. For example, if you are sending after 1 hour, your value will be 6, lower than what it was actually. Okay, so once you're sending a lab glucose, please send it immediately. Another very important, a very new method of glucose testing is a subcutaneous continuous glucose monitor. Okay, so what is this? This is a picture from which we did a study in CMC Vellore, where we actually saw what is better, a continuous glucose monitor or a random sugar. Okay, what happens during your RBS testing is you need to prick the baby continuously. Okay, so when you're pricking a baby, might sorry, interruption. At that time, what happens is baby might develop a infection. Okay, so the nurse would be like, she wouldn't have taken the adequate precautions during pricking, and the baby might develop a infection. Okay, so that is why
Uh, no, sir. I think interfering.
am I audible now?
Yes, sir. Yes, sir.
Okay. So yeah. So the so what is a subcutaneous continuous glucose monitor? Okay. The question is, I'll Sandeep, what I'll do is I'll send you the presentation. Okay, I'm not able to connect through this. I'll send you the presentation so that you can actually start presenting that from your end.
Okay. Okay, sir.
Send it to you. Okay, so has anybody seen this CGMS anywhere, or anybody heard about what is a CGMS? So basically, it is commonly being used for your adult. What we say is adult diabetologists, adult practitioners. They have now started using that. They have now started using that very commonly for your management of diabetes. Okay, so they have now started using it very commonly in their routine practices. So at the same time, what they thought was, ki let's just start. Using it for neonates also. So actually, one of the companies, Abbott, came with this idea that let's just start with the CGMS in babies. So they did a trial, they did a study in this. During the study, what they saw was whether what happens is, the study was, what we did was we placed the glucose monitor on the baby. Okay, that's a subcutaneous kind of thing. You just need to place it once. It's a very small prick. It's there and it's on the baby's body till the time we are monitoring sugars. So at the same, what we are doing is we have placed that on the baby's thigh. Next, what happens is we'll be getting a handset kind of a monitor or a pager kind of a device will be there, and at the same time what you can see is you can continuously see what's the sugar values. Okay, you don't need to prick the baby at that time. You don't need to prick baby and you don't need to see what are the baby sugars. You will be on your handset. You want a sugar at 12 o'clock, you'll be seeing what is the sugar at 12 o'clock. You'll be seeing what is the graph, what is the pattern of sugars being up, being down, being up, being down. That you don't need to prick at all. You can get it through your CGMS method. So you will be saying ki that's a very good idea. Why not? Why doesn't, like, why we all use CGMS in our routine nurseries? Why are we actually pricking babies? So here the answer comes is that CGMS values are not very accurate in unit. Okay, so CGMS values, what happens is CGMS values is particularly low as compared to what the actual sugar is. So if your baby is developing hypoglycemia, you won't be getting the actual value what is actually happening in the blood at that time. So those values are very different from what is the actual value. So that's why in neonates CGMS is still not in practice. People are still researching about how to go about CGMS, because since it's a very good idea, your rates of sepsis definitely goes down, but at the same time the sugar values are not very reliable. So that's why in the coming few years we might see better CGMS monitors, and we might see that we are being using it continuously in our nurseries. So am I audible? Am I audible?
Yes, sir.
Okay, so now the question arises, ki what is a critical glucose threshold? So neonates, they don't show overt signs or symptoms of hypoglycemia. Okay, so not every time a hypoglycemic baby will have jitters. Not every time a hypoglycemic baby will have a weak suck. Okay, they will be manifest. They will be very normal during a hypoglycemic event also. Okay, so if you see a normal baby, you see no signs and symptoms. Even if you do a sugar at that time, you'll find that the sugar might be 28, sugar might be 30. Okay, so that is why it is very important to check those events, because a prolonged duration of hypoglycemia, it's a difficulty on a long term basis. Okay, so non-specific clinical signs, and they are very subjective. If you're going for rounds, you will feel that the baby is having weak suck, but the nurse will say, no, no, sir, the suck is very good. Your consultant will say, no, 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 the suck is very good. So it's a very subjective. A weak suck is a very kind of a subjective event. Tremors might be subjective. Some might say that's a normal tremor. Some might say that's normal jitters. So the signs and symptoms are very non-specific. So that's why what we need to do is we should, whenever we are managing hypoglycemia, we should not only consider what is a normal value. Okay, we should also consider what is a safe value for the baby, so that baby does not land up into hypoglycemic problems in the later on life. So a normal sugar, but at the same time we should have a safe critical threshold, that what is safe for the baby. As we were discussing, that different societies have a different safety level. So like AAP has 40, WH has 47. So all these, what they have diagnosed, all these they have labeled. How they have labeled, they have seen what is the safe sugar. On that basis, they have labeled those critical threshold values. So the question arises, okay, now we know what is hypoglycemia. Now we know what are the signs and symptoms of hypoglycemia, how to check hypoglycemia, we know. So next question will arise, what are the causes, why babies are developing hypoglycemia. No, so why not all babies will develop, why some babies will only develop. So here we need to know that which babies are at risk of having hypoglycemia. Okay, premature babies, small for gestational age babies, those babies whose weight is less for your gestational age, babies who are having sepsis, babies who have background of asphyxia, and also babies with polycythemia. Okay, in these babies, what happens is there is inadequate in in these babies, what happens is there is inadequate glycogen stores. Okay, and there is very less substrate for gluconeogenesis. So your SGA babies, they don't have glycogen stores. They have very less stores for gluconeogenesis. So premature babies hardly have any glycogen stores. Their substance for gluconeogenesis is hardly there in their bodies. Okay, so these babies must be definitely screened for hypoglycemia. At the same time, babies of diabetic mothers, babies with Beckwith-Winman syndrome, these babies have overproduction of insulin. Overproduction of insulin will lead to hypoglycemia. Very rarely, but Turner syndrome, hypopituitarism, these kind of babies will also develop hypoglycemia. So the question arises: which babies to be screened? These are the category of babies which you should always screen. So this coming on to the risk factors: which babies are at risk of hypoglycemia? Which babies you should definitely screen for sugars are these. Depending on the maternal condition and depending on the neonatal condition. So maternal condition, if the baby's mother is having diabetes, please do check sugars. If the maybe mother is receiving some beta sympathomimetics like terbutaline, please do that. If mother is receiving extra intrapartum dextrose infusion, okay. So once the baby is getting continuous sugar during the infusion time, once the placental link is separated, at the time baby will develop a rebound hypoglycemia. Please check that. Preeclampsia mothers, their babies are at risk of hypoglycemia. Similarly, if you see the neonatal conditions, same thing: prematurity, small for gestational age, asphyxia babies, large for gestational age babies, babies with sepsis, baby with polycythemia. These all babies, you should make a protocol in your unit that these babies must be checked for sugars during their stay in the nursery or during their stay even in the postnatal wards, so as to manage hypoglycemia, diagnose hypoglycemia, and to prevent long-term no developmental problems because of hypoglycemia. So question arises: okay, sir, now we know that what is hypoglycemia, which babies to be screened, what values to be checked for, what symptoms to be checked for. That till what time we need to check sugars? Baby will be there for for some preterms will be there for 15 days, 20 days. We cannot check sugars every day. Yeah, the question is you cannot check sugars every day. Okay, so at risk units, you have to check for example, a preterm baby is there, a small for gestational age baby is there. These babies are at risk of hypoglycemia for the first 72 hours. Okay, for 72 hours, these babies are okay. Then later on, they have very less risk of developing hypoglycemia. Then they'll be because of some other, for example, a premature baby develops sepsis. At that time, he might develop hypoglycemia. Okay, so if a premature baby with the hyperinsulinism, so like he'll be in the initial few days for the first 72 hours when the glucose levels, when the processes, when the metabolic processes are just adapting. Baby is just developing how to do glycogenolysis. Baby is just developing how to convert the sugar from the milk into the blood sugar. So at during this transition phase, first 72 hours is very critical. During that time, when the transition happens, if we check sugars for these babies, we can prevent and manage hypoglycemia. Similarly, in sick infants, if you are admitting a baby is very sick, baby has sepsis, or baby is having shock, during that time, a routine sugar monitoring must be there. Why sugar monitoring should be there? Because these babies are at risk of hypoglycemia. Okay, why at risk of hypoglycemia? Because if a baby is septic, okay, so the bacteria in the blood will consume glucose more. So baby, instead of baby utilizing the glucose for his or her own growth, his or her own metabolic processes, the bacteria will start using glucose more. So the baby's sugars will start falling down. So please do check for these babies every 6 to 8 hours. Okay, once their baby is out of danger, out of the septic part, then you can always reduce your sugar monitoring. That is the crux. So in your postnatal wards also, if you are, for example, a term 2.2 kg baby, please do check sugars for the initials for 72 hours. A term baby large for gestational age, please do check sugars. A term baby with who's infant of diabetic mother, please do check sugars regularly for these babies. Okay. So why do you need? Why I am stressing the need for sugar monitoring in these babies? So what happens is this is a very famous study. So what it says is what they have seen is ki, what is the incidence of hypoglycemia. Okay, so incidence of hypoglycemia, they actually did this study for around 500 infants who were considered high risk, more than 35 weeks. They did this study for high risk babies, and then they saw that how many of those had hypoglycemia. They did routine checking mein what they found was 51% of the first category, 51% of babies during the stay had a sugar of less than 47. Similarly, 19% of out of the 500 infants, 19% had a sugar of less than 36 during the stay. Similarly, how many of them evolved in the first 6 hours? 48% of the babies evolved had a hypoglycemic in the first 6 hours, while in 81% of the babies developed hypoglycemia in the first 24 hours. And if we see that hypoglycemia evolved after three normal values, so you will see keys, values are normal, but the fourth value came down. 37% of babies had this problem that three sugars were normal, but the fourth value came down. Median duration of an episode, what they saw was around 1 to 2 hours, baby was in an hypoglycemic event. So the crux of this slide is that babies at risk definitely have a very very high potency of going into hypoglycemia. The crux of this slide is, if you check sugars, you'll be able to see that okay, yes, babies do develop hypoglycemia and they do have symptoms of hypoglycemia, but if you don't check sugars, then you won't even realize okay that the baby is in hypoglycemic state. Okay, and this is the same thing. So why I am stressing more upon that, why you should check sugar? Okay, the question arises, sir, you have discussed a lot about sugars, you have discussed a lot about what is the critical value, you have discussed about how to check sugars, but why are we actually checking sugars? You know, what is the problem with sugars? Okay, babies with 36. What is the problem with the 36 sugar? What is the problem with the 30 sugar? Baby will have some symptoms at that time, and that will settle. Okay, you will give some feed, baby will stop having those symptoms, and then baby can go home. No, the question arises, the question is, the important crux of checking sugars is the neurological outcome. What will happen once the baby develops a hypoglycemia? Okay, so what we the this slide says is, if the baby is having seizures because of hypoglycemia, baby is that bad hypoglycemic, then and baby is manifesting seizures, 50% of those babies will have a bad neurological outcome. Okay, so basically, what neurological outcome can happen? The baby will have a damage to the parieto-occipital area. The parieto-occipital area is the most common damaged area after an hypoglycemic event. So, baby parieto-occipital area actually will, guide the baby's visual development. Baby will that will guide the baby's mental development, the IQ part, the visual part, that is a very important area. So babies IQ, babies vision will definitely be affected. 50% will have definitely a problem in the parieto-occipital area. If the baby is not having seizures but having some neurological features, for example, baby might be weak suck, baby might be lethargic. Okay, 12% of them will have a abnormal outcome. If without neurological features, you just find a hypoglycemia, that okay, baby is completely fine, but baby has a sugar of 40 at around 48 hours of life, 6% of those babies will have hypoglycemia, will have a bad neurological outcome. Okay, so this is some one of the very important take home message from here, that while you are checking sugars, you are actually preventing brain injury. Okay, you are preventing brain injury by reducing your rates of asphyxia, by having good obstetric care, by having good resuscitation. But sugars, you are seeing it is very common. You'll be seeing a lot of small for gestational age babies, lot of infants of diabetic mothers. So if you are checking sugars for these babies, your long term neurological outcome will definitely improve. Okay, so that is why we are stressing so much about diagnosis and management of neonatal hypoglycemia, so as to have a better future for the baby in life ahead. So, what was the prognosis if a baby is having hypoglycemia? Baby might have intellectual dysfunction, visual disturbances. Baby might have motor deficits in form of spasticity, ataxia. Baby might have seizures in the life ahead. The brain might not grow properly. Baby might land up in microcephaly. Hence, hypoglycemia evaluation is very important. So now everything well said and done. Ki okay, we need know what babies to be screened. We know till what time you need to screen the baby. Now, what to do if a baby is having hypoglycemia? Okay, so during your round, you saw that okay, baby's 2 hour old baby breastfeeding was not established. You saw that the baby's sugar is 38. Baby is not having any symptoms, but you saw that the baby's sugar is 38. Okay, baby, but mother is not there, mother is still in the labor room, mother is still for example, mother is bleeding, mother is having the sutures being taken. At that time, what to do? Okay, so a novel therapy, it's not a very novel therapy, not a very new therapy, but it's a new therapy if you consider the Indian aspect, that is called as an oral dextrose gel. Oral dextrose gel, what this study was done, this was done in USA. So what they saw was ki, cost for a regular newborn admission is around, was around $4,000 US. But if you're treating hypoglycemia with the oral dextrose gel, the cost will be just the same. For example, around $5,000. But similarly, if you are treating hypoglycemia with an IV dextrose therapy, the cost increases 6 times. Okay, $30,000 for a baby to be treated hypoglycemia with IV dextrose. So, how you can prevent that $30,000 if you are using an oral dextrose gel in your unit? That will definitely reduce the cost for the baby. Okay, so how to use that we'll be seeing. So the dose will be around 200 mg per kg. Okay, so we get oral dextrose gels. That is not very common in India. This is from studies from the US. So you will see, but it's not being regularly used in a lot of NICUs. So what you need to do is you need to squeeze a weight based dose into the syringe and dry the buccal cavities. You dry the buccal cavities first, okay, with a gauze piece. At the same time, you on a glove finger, just take it and apply on the inside of the gums, okay, inside of the buccal mucosa. Okay, massage on this side, massage on this side. So keep on alternating till the entire dose is complete. Okay, so this definitely has proven, the studies have, a lot of studies have proven that oral dextrose gel, if you use, your hypoglycemic events definitely reduce. So oral dextrose gel done. Now the question arises, sir. Okay, sir, we don't have a, we are in Kutch, we don't have oral dextrose gel available. Now how to manage hypoglycemia? Okay, so okay, now we'll be discussing that. This is the management part. This is one of the very important slides. How to manage hypoglycemia. Now you have known what to babies to be screened. Now you know when to screen. What is the sugar value, normal, abnormal? What are the long-term outcomes of a hypoglycemia? Now you are in a pediatrician mode. You know, key, I know want to treat hypoglycemia. So you just tell us how to treat hypoglycemia. Okay. So what we are going to see in this very important slide is, so this is from actually AIMS protocol. So if you get a sugar of less than 40, you set a target of less than 47, or you set a target of less than 45. Okay. If the baby is asymptomatic, between 20 to 40, you get a sugar value. Give a trial of oral feeds. Baby's weight is around 2.5 kg, just a 2 hour old baby. Give a trial of oral feed. Give at least 15 to 20 ml spoon feed, or give a trial of breastfeeding at that time. You repeat the sugar after 1 hour. For example, you got a sugar of 35. You gave feeds. Baby was asymptomatic, no symptoms at all, completely fine baby. You just did a random blood sugar, a 35 sugar. So you give feeds and you recheck the sugar after 1 hour. Okay, so if the sugar is 45 at the after 1 hour, initial 35, gave oral feeds, then it changed to 45. Nothing, just continue on feeding, just press on lactation, just press on, giving the feeds more often. But at the same time, you need to continuously monitor the blood sugars. Why? Because once the baby has developed hypoglycemia, baby is at risk of having multiple hypoglycemic events. So please monitor the sugars. Once the lactation is well established, after 48 hours, you can stop the sugar monitoring. Okay, if everything is fine, your lactation is well established, baby is sucking well, you can stop the sugars after 48 hours. Okay, now what to do if the sugar you checked at after 1 hour is 35? You gave a trial of oral feed, but the next sugar comes at around less than 30, or it comes around 28. So at that time, now you cannot, you have given one trial of oral feed, please don't give a repeat. Please don't give a repeat trial of oral feed. Please don't give. You have had 2 episodes of hypoglycemia. This is now the time where the baby should now be admitted in nursery for IV dextrose infusion. Okay. So baby, why? Because you'll give again an oral feed. You'll again see that the baby, whether baby is latching, baby is feeding or not. So that duration of hypoglycemia will be very long. So what AIMS protocol says is, once you have had a sugar, 2 sugars, low sugars means that the baby must be admitted for IV dextrose infusion in the nursery. Okay, so this is for 20 to 40. Anytime less than 20, you need to give a bolus. Anytime less than 20, or anytime any. So what we CMC protocol was anything less than 25. AIM says less than 20. CMC where there we used to follow anything less than 25, irrespective of symptoms. Baby is completely fine at 24, please do a dextrose bolus. Okay, baby is having seizures, so definitely you need to give a dextrose bolus. But at any value less than 25, please give a 2 ml per kg or a 200 mg per kg of 10% dextrose bolus. Okay, so what you need to do, for example, baby's weight is 2 kg, give a 4 ml IV 10% dextrose push. At the same time, now next what to do, you cannot start the baby now on oral feeds. You cannot. Okay. So once you have given a dextrose bolus, baby has to be started on IV dextrose infusion. Okay. Later on, once the sugars are normalized, you can again restart feeding. But once a dextrose bolus has been given, please keep in mind that you need to continue the baby on IV dextrose infusion. IV dextrose infusion should be at a glucose infusion rate of minimum 6 mg per kg per minute. Okay. After that, you need to continuously monitor sugars. If the blood sugars are increasing stably for more than 50, then what you can do is you can see that okay, you can continue, you can slowly taper it off, you can slowly taper the sugar monitoring, you can slowly taper on the dextrose infusion, and you can simultaneously increase the feeds at that time. And once the baby is completely on feeds, sugars are completely normal, baby can be discharged. Okay. But if the even after 50, even after giving a bolus, starting a baby on dextrose infusion, you are getting a sugar persistently of sugar of less than 50, then what you need to, you have started with a 6 mg per kg per minute of GIR, further hypoglycemia, increase it by minimum 2 mg per kg per minute. So go to 8. If even after 8 you get hypoglycemia, increase it to 10. Even after 10 you get a hypoglycemia, go to 12, 12.5. Okay. So 12.5, you cannot more than 12.5 if you are requiring, you cannot no give it via peripheral line. At that time, you need to take a call on inserting a UV line or inserting a peripherally inserted central catheter. A PIC line or a UV line must be inserted for all dextrose infusion with GIR more than 12.5%. Okay. At that time, we need to do further workup why the baby is developing hypoglycemia, which we'll be discussing in the next few slides. So the crux of this slide is any hypoglycemia, if the baby is asymptomatic, like for example, any hypoglycemia between more than 25, if you are getting a 28 sugar, baby is symptomatic, give a trial of oral feed. Okay. Repeat the sugar, repeating sugar. If it is coming, if it's increasing, 28, say it is 35, then you can always, just wait. If it is still persisting low, then you can always always have to start the baby on IV dextrose infusion. If symptomatic, definitely you don't have any other option. Please start on dextrose bolus as well as a IV dextrose infusion. So this is something, this is a slide which which will tell you what is a GIR. What is GIR? So GIR is glucose infusion rate, 6 mg per kg per minute. That is your basic what we usually start in our nurseries. That means what is GIR? Glucose. That what does this mean? That 6 milligrams per kg per minute the glucose is being provided through your IV dextrose solution. Why 6 is being required? Normally, in a baby, normal GIR, a baby who's on full feeds, the normal glucose utilization is around 4 mg per kg per minute. Okay. So once a baby has developed hypoglycemia, you need to go something ahead of 4. So something ahead of 4 is 6. So babies usually have a GIR of inside what's happening. The glucose utilization rate is around 4 mg per kg per minute. So what you need to do is you need to give something extra over 4. So 4 say extra is you start with a 6 mg per kg per minute of a GIR. If once how to make 6 mg per kg per minute, if you are starting on day 1 60 ml per kg, make it 42%, 42 ml of D10, 25 ml of D25. Similarly, if day 2 day 3 75 90, this is the chart how you can go through about the GIR infusions. So 6 mg pe how much D10 you need, 8 mg pe how much D10 you need, 10 mg pe how much D10 you need. So this is the a rough value of what is a GIR and how you can make those infusions in your nursery. So next question arises ki if a baby is having hypoglycemia, what could be the causes of baby having a hypoglycemia? It might be sepsis, it might be a CNS disease, which might be no like what are the common what we call as common masquerades of hypoglycemia. What all diseases mix hypoglycemia? Sepsis might mimic hypoglycemia. Baby might be dull at that time. CNS disease, baby might have a hypoglycemia. If a baby is, for example, hypocalcemic, hyponatremic, the symptoms might be similar to hypoglycemia. A baby with heart failure, renal failure, liver failure. So these babies might mimic symptoms of hypoglycemia. So always have it in your mind that okay, a baby might be hypo. You are thinking that the baby might be hypoglycemic, but at the same time, baby might have some different manifestation altogether. So don't just fix onto the thinking, okay, baby is having hypoglycemia, let's just manage hypoglycemia. You can, or you should always think on a parallel track that okay, this might be something else also, because it's a very, babies will won't don't have a variety of in manifestations. We will have some with lots of diseases will have the same manifestations. So always in your mind you should have a parallel thinking that okay, if it is not hypoglycemia, then it is what? Okay. So now the question arises, sir. Okay, I have started the baby on, baby had a sugar of 25. I gave a bolus. I started the baby on dextrose infusion. I started initially on 6 mg per kg per minute. I increased to 8. I increased to 10. Baby was still hypoglycemic. Now I have inserted a UV for a 12 mg per kg per minute of GIR. Baby still hypoglycemic. Now what to do? So at that time, this is the definition of recurrent hypoglycemia. If you are not able to maintain sugars even after 12 mg per kg per minute, or if your baby is not able to reach full feeds because of hypoglycemia even after 7 days. Okay, so what you did, you started on IV fluids on day one, you started some feeds, but baby started having hypoglycemia. So you're not able to actually go up on feeds or reduce your IV fluids even after 7 days. That is the time where you have to label the baby as a recurrent or a persistent hypoglycemic event. This needs to be investigated thoroughly. Okay, this is a very gray area. Not a lot of pediatricians know about it. Not a lot of residents have been in touch of this. So critical hypoglycemia. This is a persistent hypoglycemia, or recurrent hypoglycemia. At that time, what you do, if you are on 12 mg per kg per minute, or your baby is not able to reach full feeds even after 7 days, you check a sugar. You get a sugar of around 30 on day 8 of life. On these two, if babies any of these two, on 12 mg or not able to reach full feeds, at that time you get a sugar of 30. You need to send critical samples. Okay, what are these critical samples? Lab RBS, as I told you, you have to send as soon as possible to the lab. At the same time, you need to do a serum insulin. You need to send a serum cortisol and an ACTH. At the time, if you want to do, you also have to do a urine ketone. At the time, you need to see whether urine ketones are present or not. Please send for urine reducing substance. Urine reducing substance is very common in for cases like galactosemia. You send a urine reducing substance. Also do a blood gas for lactate. So these are some of the samples which you need to do at this time, at the time of hypoglycemia. You need to send to lab immediately at the time so as to get a correct values. So what this slide is about, this slide is mm, mhm. Okay, so what to do? What to do once the baby develops hypoglycemia? You have sent a critical sample. Critical sample may what you included was you included insulin, ketones, free fatty acid, cortisol, growth hormone, lactate. So very rare, but then you need to keep this in mind, what all can be the differentials of a baby having recurrent hypoglycemia. At the same time, you also need to send a ammonia level values also, because ammonia will tell you, a normal ammonia will have different diagnosis, a high ammonia will have different diagnosis. For example, if you have a low beta hydroxybutyrate, baby is having high free fatty acids, and the insulin is low, you need to learn about, you need to know about fatty acid oxidation defects. Similarly, if the lactate is normal with a high beta hydroxybutyrate, high free fatty acid levels, at that time you need to look about a pan hypopituitarism. Get an MRI done, do a cranial USG, look for pituitary, look for any other manifestation of a midline defects. So these are some of the values, these are some of the tests which you have to do in at the time of a persistent or a recurrent hypoglycemia, so as to rule out the very rare causes of hypoglycemia. These are very rare, but once if you detect it well in advance, then the babies, we can always change on to the therapy. We can always add on to the therapy so as to increase the sugar values. So very common cause of hypoglycemia, as we discussed in an etiology slide, that is called as a hyperinsulinemic hypoglycemia. Okay, hyperinsulinemic hypoglycemia, how to detect that this is the hyperinsulinemic hypoglycemia? You will get an insulin level of more than 2, a beta hydroxybutyrate level of less than 1.8, free fatty acids will be low. So this is the time where you need to know whether it's an hyperinsulinemic hypoglycemia, because your treatment is there for hyperinsulin. If you get that, you can always start on to the therapy. Okay, that's why you need to rule out whether it's an hyperinsulinic or a normal insulinic hypoglycemia. So again, this slide is definitely is pointing out to the investigations you need to do in resistant hypoglycemia: insulin levels, cortisol levels, growth hormone levels. Okay, please do a ammonia level also. If you are very confident that it might be a genetic issue, please do a TMS at that time. That will help you. Urine ketone, urine reducing substances for if you're suspecting a galactosemia, urine GCMS. Similarly, if you're suspecting, for example, a metabolic issue, please send a urine GCMS levels also. Okay, now sir, you have told us a lot about how to manage hypoglycemia, how to give feeds, how to make a GIR, what to do with the if baby is not having persistent hypoglycemia, how to treat persistent hypoglycemia. For example, peripheral level doctor will say, sir, we don't have these luxury of doing all these tests. Now, what should I do if I'm getting a persistent hypoglycemia? Please start the baby on hydrocortisone. Hydrocortisone 10 mg per kg per day. PD will definitely help you get some time for actually sending a baby or referring a baby from peripheral to a tertiary care level. Hydrocortisone will it reduces the peripheral glucose utilization, and it will help in increasing the gluconeogenesis, so it will give you that time. Okay, even if it's a diazoxide is not a very commonly available drug, but this will always help you. For example, if you're getting a hyperinsulinemic hypoglycemia, please start on diazoxide, that is 5 to mg per kg per day. TDS usually you will get in a tablet form. Okay, a capsule form is actually there of diazoxide. You need to dilute it and give it to the baby. This will at the same time you need to also look out for hypertrichosis. Okay, that's not a very important side effect, but fluid retention and cardiac failure is very common in diazoxide. Please be very careful while starting diazoxide. Other drugs are octreotide and glucagon, not very commonly used because people don't actually discuss with the endocrinologist what to do. Am I audible? Hello? Hello?
Yes, sir. Yes. What is?
Okay.
Sir, you're muted. Muted.
Okay. Sorry. Yeah. So now the question is, you need to do what you need to do is start on hydrocortisone. If you're not getting any reason for hypoglycemia, at least try to increase the glucose values till the time you actually discuss with the neonatologist, till the time you actually discuss with the endocrinologist what to do. Hydrocortisone is actually a life-saving drug. Even it's available even in the remotest of the country, remotest of the parts of the country. Start the baby on hydrocortisone, and then we'll see that how to manage the further episodes of hypoglycemia. So outcomes. Okay, so transient hypoglycemia will have usually will have a good prognosis. Okay, but if we see do MRI of babies with hypoglycemia, we do see involvement of the parieto-occipital areas very commonly. Okay, so that is something which we need to focus, which we need to counsel the parents, that if a parent is coming showing you that at 2 years of life they did an MRI for seizures, they saw that the paradoxical areas are hyperechogenic. At that time, you just go back into the history and ask how was the feeding in the first few days, what was the birth weight of the baby, whether any sugar testing was done. If you do that, if you go retrospectively, you'll find that paradoxical area more commonly it is linked to an hypoglycemic event. Very important thing is it is very difficult in preterm infants that the baby is having a hypoglycemic event. We might have birth trauma, baby might have hypoxemia. Okay, these are very common mimickers of hypoglycemia. You should always know that mimickers of hypoglycemia are always there. Baby might have tachypnea. You will be thinking it's a TTNB, but at the same time, baby might be having an hypoglycemic event. So be very careful, because hypoglycemia per se you don't have any very wide variety of symptoms. So always be very careful whether this could be an hypoglycemic event. Whenever you are seeing a baby, whether you are some symptoms are there, please see whether it's a hypoglycemic event, or please see it's a kind of a sepsis kind of, or it's a tachypnea, something like that. You need to take a call about. Okay, so same thing that I'm pointing out here. This is the parieto-occipital areas hyperechogenic. Okay, why do you need to look for hypoglycemia? The question is, okay, what is the problem with hypoglycemia? Okay, baby had a sugar of 30 at 2 years. Baby had a some seizures. Baby had, which we were able to manage. Now the question is, lot of countries around the world, they're actually they're having a lot of lawsuits against neonatologists and pediatricians. Why? Because at 2 years, baby had a poor neurodevelopmental had a developmental delay. Baby had an MRI of parieto-occipital area involvement, and the lawyer saw that okay, baby was small for gestational age. They did not check sugars, or they checked sugars, but it was not managed properly. They just gave oral feeds. Baby had persistent hypoglycemia, but they still did not act according to the plan. That's why medico-legally also your hypoglycemia is coming out to be a very common point where doctors are being sued in countries like US, UK, Germany. Very common that hypoglycemic event are being happening and they are being taken out into the legal circles very seriously. So be very careful with hypoglycemia in the coming few days. Initially, in 1960s, if you ask me, even sugars up to 20 they used to tolerate. 1970s up to 30 milligram deciliter sugars, the neonatologist used to, the pediatrician will be like, okay, 30 only, na, it's okay, we can manage with feeds. But now, and when with the rising medico-legally issues, the problem is increasing day by day, that even all hypoglycemic events need to be documented. You need to document what you did for the hypoglycemic event, how the management of hypoglycemia happened. So these all things, if documented properly, if you know properly that okay, we should manage how to manage hypoglycemia, you document it in your records, then you are very safe in the even if the baby lands up into a long-term neurodevelopmental problem. Even if you land up into a medical legal case, you have a documentation, you manage like this, then you are safe. Okay. So hypoglycemia is a, is a where even 1 milligram of value matters a lot to the baby's long-term outcome. Every milligram matters. Hypoglycemia. So question arises, now we know everything about it, but what if we don't even want that the hypoglycemia event should happen? Antenatally, what you can do is you need to prevent it. No, you need to prevent preterm births, good antenatal care to prevent fetal growth restriction. Asphyxia event should be, you need to prevent, and had to have a adequate control of maternal hyperglycemia. Prenatal prevention. Postnatally, how you can prevent it? Please start breastfeeding as soon as possible. Skin to skin contact will help the baby in developing, in the mother developing good lactation. Do screening of at risk infants, as we discussed: LGA babies, IDM babies, small for gestational age babies, preterm babies. These should be, screened very carefully in your postnatal rounds. Please prevent hypothermia. Hypothermia predisposes to hypoglycemia. Our criteria was, if a SGA baby is there, please keep the baby for there in your wards for 72 hours, because initial 72 hours are very critical. They tend to develop hypoglycemia. If 72 hours, we used to do sugars at CMC. We used to do sugars every 6 hourly for babies who were small for gestation age, who are preterm, who are low birth weight. And if after 72 hours, if the sugars are normal, then only we used to discharge the babies, because we knew that these babies will land up in hypoglycemia. So that's why we used to screen them. Once the 72-hour sugar was normal, then only the baby gets discharged. Similarly, if you have that luxury there that you can keep the baby for 72 hours, please establish breastfeeding and please do regular sugar monitorings, and do document the normal sugars before discharge, before discharging the babies. So if you timely recognize these clinical signs and prompt management happens of hypoglycemic events, then the long-term outcome will definitely, improve for babies. If you want to take a take-home message, so always, interpret in clinical context. Hypoglycemic event, first 24 48 hours, the values might be haywire, might be low, might be very high, because baby still, adapting to the neonatal life right now. So the because of impaired hormonal and metabolic responses, hypoglycemia might happen. If the baby is not able to reach full feeds in the background of recurrent hypoglycemia, please do investigate for persistent hypoglycemia. Usually, transient asymptomatic hypoglycemia will have usually it has a good prognosis. So yeah, that's it from my side. Any questions if there, can always ask.
So thank you so much for a wonderful session. Some points I would like to highlight for our residents also. One thing which we are also following in our unit is that, because inside the NICU, we are most of the times dealing with sick babies. I mean, some baby would have asphyxia, some baby would have some other issues, some baby would be a premature on ventilator, RDS. So, whenever you are dealing with sick babies, because there is not much of evidence as to what is the exact safe value, it is like Sir also told that, I mean, it is better to be on the safer side. You try to keep a higher cutoff. So, that is actually the reason why we also follow cutoff of 60 beyond 48 hours of life, because, I mean, most of our babies are sick babies. Someone would have sepsis, someone would have RDS, someone will have some other issues. So because they are critically sick babies, it is better to be on the safer side, though majority of the literature says a value of 47 or 45, but the Pediatric Endocrine Society has given a value of 60. And I mean, all the guidelines, they say that even more research needs to be done. So till the time we get the best evidence, at least for your sick cases, I would always be on the safer side, and I would prefer a value of more than 60. Second is, as sir pointed out, that the first 72 hours is the period of transition. So majority of the events of hypoglycemia would happen in that time, because the metabolism, it is getting into sync, and there are many transitional changes happening in the first 72 hours. So majority of the times, if you have an SGA baby who has not developed any hypoglycemia in the first 72 hours, there are very little or minimal chances that he may do so in future. Okay. Third is, why the topic is important. So, the most important part is that even a single episode of hypoglycemia can have an impact on the long-term neurodevelopment. So, you imagine a SGA baby who is otherwise normal. A child who is just small for gestational age, but everything else is normal. He has no sepsis, no birth asphyxia, no RDS, and just because he had an episode of hypoglycemia, his entire life gets compromised. So
Yes.
that is why it is very important to screen. I think now residents would understand why I'm very particular that I want sugars to be assessed every day morning, and like it should not be missed, or it should not be something that is not acted upon. And lastly, I just had one question, sir. Like in CMC, if you had a baby with recurrent hypoglycemia or persistent hypoglycemia, so what would be the first drug you would use there?
So, yeah, the same thing. So, if you are suspecting a hyperinsulinemic hypoglycemia, okay. So, see, if we know that this is a infant of diabetic mother, okay, they might have a hyperinsulinemic kind of a background. Okay, so at the same time, what we initially used to start with diazoxide. Okay, diazoxide they used to prepare in the pharmacy, and they used to start on diazoxide. Okay, but at the same time, if you are not very sure what is the cause of hypoglycemia, and diazoxide actually needs some preparation. You need to ask the pharmacy to prepare and all. So if in the middle of night, if you're not able to, you have started now, have babies have starting to have hypoglycemia, we used to start with hydrocortisone. The problem with diazoxide is it's not readily available. The diazoxide you need to prepare for a neonate. Hydrocortisone on the other side, it is a drug which is very easily it's common, and till the time you get a value till you diagnose, you get a cause what is happening. So for example, a low cortisol or a high ACTH, it's a cortisol deficiency, so then hydrocortisone will work. Similarly, hyperinsulinism is there, diazoxide will work. So on the clinical context, you can always change on to the drug. If you're not having any drugs per se, diazoxide is not available, you can always start with the hydrocortisone. So it was a kind of a mixed, some babies will get hydrocort, some babies will get diazoxide, but on a more commonly, we used to have a diazoxide ready at bedside for babies who are at risk of having hypoglycemia.
Okay. Okay. And any experience with using octreotide? Also?
No, no, no. So octreotide, actually, we actually didn't. I don't know. It's a good thing or it's a bad thing that we actually did not land up into using octreotide for hypoglycemia. So that's something
Okay.
which I think I missed in during my residency. Hopefully, in the coming time, we might see octreotide being used for hypoglycemia.
Okay.
Yeah, yeah,
Okay.
yeah.
Okay. And so just last one point for the residents also. And I think because many times when the name comes up, na hypoglycemia, everyone feels that उसमें क्या है? ये तो सबको आता है. Okay. But
Exactly.
the problem is that, like, if you go through the entire presentation, there was not a single Indian study. So
Mm,
we are the population who has the biggest load of SGA babies, the biggest load of babies with birth asphyxia, biggest load of prematurity. Okay, but all our studies which are defining our guidelines have come from US, where the incidence of hypoglycemia as such would be much less than what we have in our community. So it is
mm,
high time that we should have some good quality studies from India, especially on this matter, because
mm,
our guidelines have to be from our population, not from something coming from the West. And we have seen, it is just a personal experience, but we have seen that these SGA babies. There are certain studies where they say that if you are in a setting where you cannot keep them for 72 hours, if the child like what you showed also in one of the slides, that the probability of developing in the first 24 hours is quite high. So if in the first 24 hours the SGA child does not develop hypoglycemia, you can to some extent be sure that okay, he will not develop. But
yes.
I have seen it in my practice or in the past few years that like we see a lot of cases becoming hypoglycemic on the third day or sometimes even on the fourth day, where the initial few sugars were normal. So,
Yes.
I mean, it is high time that India should have some good quality studies for hypoglycemia. It is one of the very gray areas. We are just actually, I mean, moving into the dark, but we do not know what exactly is the right value and beyond which point we should consider treatment, beyond which point we should stop treatment. All those are actually the gray areas.
Yes.
So, if there are no other questions, I think we can stop. Thank you
Sir,
very much once
I
again
have I
for
have
the
a
wonderful
question.
session.
Ah,
Yeah,
tell.
yeah, please.
Sir, uh, do we give, uh, we are uh, uh, giving a minute of glucose infusion to central line. So can we give in divided doses from periphery in 6 mg from one side and 6 mg to other side? If we don't have the facility of central line in periphery.
Okay, so the question is the volume will be too much. Okay, if you are giving a 6 mg to one line and the other, so you have to give a very the volume of glucose will the volume of fluid will be too high. Okay, so you need to give adequate fluid for the gestational age, and at the same time you need to have a higher sugar concentration in that fluid. Understood. So if you're giving, for example, 6 through one line, 6 through other line, you'll be giving a 120 ml per kg. Whereas you baby is a day one old baby only. Okay. So why we are increasing the concentration? Because at the same time, we are preventing over fluid. We don't want a fluid retention to happen. That's why we are giving more dextrose concentration in that fluid in the same volume. That's why the sugars are high. That's why divided dose won't help, because at that time the volume of dextrose will be very high, volume of fluid will be very high. That might land up, baby might land up in cardiac failure, baby might land up into fluid retention. So that's why we are stressing more upon to 12.5. You see, you can give even if you don't have any no central access. You can also you can give 12 point more than 12.5 through your peripheral line. That can be given, but the results won't be that good as compared to a central line.
Okay. What if we divide the volume also? If we are giving 12 mg in 50 ml, so 25 from the one line and 25 from the other line. So it will be result will be same, or maybe it is less compared to those in central lines.
Okay, Sandeep, you want to answer this?
Yeah. So, so I mean, see, the point is that if you are giving 12 mg per kg per minute in 25 ml, I think that concentration of dextrose in the fluid will be very high. Okay. I mean, why are we worried that at any point of time, the concentration of dextrose which you are giving in the fluid, it should not be more than 12.5%. Okay, like 10% dextrose is safe to give from a peripheral line, but at the same time, you cannot give 25% dextrose directly through a peripheral line. Okay, so I mean, if you are giving such high glucose concentration, 25 ml, that fluid will be very much concentrated. I mean, sometimes, I mean, we have seen babies with persistent or refractory hypoglycemia where even we have to use 50% dextrose. So in those cases, like if you cannot use a peripheral line, I mean, no matter how small the volume is, but the concentration of dextrose in that fluid is too high, and that is sufficient to cause thrombophlebitis and other medical issues. Okay, so it is always to be on the safer side that if you're using at any point of time the concentration of dextrose in your solution, if it is exceeding 12.5, you should move to a central line.
Yes.
Hmm. Thank you, sir.
Good. Good question. Okay, Sandeep. I think it was a very good initiative by you to take to organize a seminar on a very gray area topic, hypoglycemia, because we don't know much about it as residents, but at the same time, nobody, like, there's not much what we call as very much focus on hypoglycemia. Will be more about RDS, asphyxia,
HIE, and all these things, hypoglycemia at the same time needs equal importance. And because obviously it's a manageable brain injury, manageable cause of brain injury, and it will always help in your long-term good outcomes. So thank you so much.
Yes.
Yes.
Yeah,
So
it was
well,
pleasure to have you, sir, and
sure,
hopefully in
was
future we can have you again, and maybe sometime in future you can plan a physical session also. We'll be happy to
definitely.
host you
And
here.
always plan that also. We can do that. We'll soon do it. Okay. Yeah. Thanks, Sandeep.
Yeah,
Bye. Yeah. Bye.
yeah.
Yeah.
Bye. Thank you so much.